Hello guys, welcome to our channel. Today we are going to discuss about the part 3. This is the last part. In this I am going to cover the very few topics only: gastrointestinal, endocrine and the reproductive system. And remember that again the endocrine will be revised along with the medicine. Gastrointestinal, some of the topics will be revised with the surgery. And reproductive, you all know that it will be revised by the mostly female reproductive system will be revised in the obstetrics and gynecology. So let's start the discussion. Those who are new to this channel, please do subscribe and share with your friends. Coming to the gastrointestinal tract, you also have to remember the taste buds. Okay, so basically in the tongue, you see the most anterior part will be for the sweet, and the corners, the periphery region will be the salt, and the middle part will be the umami, and the again the corner part of the base nearby the base, it is the sour and the bitter. Okay, so how this taste and what are the receptors they present? So taste is present in the all over the tongue except on the filiform papillae. Okay, next, sweet, it is going to be the G protein coupled receptors T1 and R2 and T1 R3. Next, salt is ion gated, which will be epithelial sodium channel. Sour is also ion channel, and it is also going to be like epithelial sodium and HCN and also TRP. Bitter, G protein coupled receptor T2R. Umami, G protein coupled receptors monosodium glutamate and also T1R1 and R2. So these is already asked in the exam, and this is also already asked in the examination. Next, coming to the nerve supply, the two thirds will be supplied by the chordae tympani for the taste and lingual for the sensory. Next, one third will be supplied both the taste and the sensory by the glossopharyngeal, and the base will be supplied by the vagal for the both taste and the general sensation. Next, coming to the hormones, you can see these are the gastric, how the cells will be seen. This is the enteroendocrine cells, chief cells, parietal cells, mucosal, and the surface cells. These are the important cells that play the role. Let's see what are those roles. For example, here you can see the gastrin, which will be traced by the G cells, and it will increase the gastric motility, acid production, and it will also cause the contraction of the lower esophageal sphincter. Next, cholecystokinin is secreted by the eye cells. It is also known as a pancreozymin. And what is the main action of the CCK? It will contract the gallbladder and also relax the sphincter of the OD. And indirectly, it will increase the secretin action. So it's like a friendly action. For example, see the secretin, it will increase the CCK action. And secretin will decrease the gastric acid production and also contract the pyloric sphincter for the more movement of the digestion. Next, ghrelin is an hungry hormone, leptin is an satiety hormone, GIP, and this is the gastro inhibitory peptide which will increase the insulin levels. This is the vasoactive, and this will cause the relaxation. So these are some of the important hormones and their mechanism. Next, coming to the another important topic, that is the iron metabolism. Whenever we take iron, that is in the Fe3. Okay, that is in the Fe3. So you can also see on the beside of the uh, common prescription, whatever the drug we written, that is a ferrous sucrose or like that, right? So we take the ferrous in the form and it will be going to converted as a ferric. Where is the most common location it will go? It is going to act on the duodenum. Okay, it will act on the duodenum. So once it reach, it is going to convert the main important form, and later on it will enter the duodenal cells. So with the help of what is this, this gate is DMT1. Okay, this is the DMT1. Through the DMT1 it will enter into the whatever we have here, the cell, gastrointestinal cell, it will going to enter. Once it is enter, again it is going to convert back for the storage form. This is the one which we are going to test during the labs. Serum ferritin levels, how we are going to check? With the help of this only. So this storage form only will give us the estimation how much iron is there in our body. And remaining iron which will be going to come back to the circulation. How? With the help of the ferroportin. On the basolateral region, it is going to come via ferroportin into the circulation. Once it is going, we came back to the circulation, again it has to convert it into the Fe3. With the help of the heparin, it is going to convert, and then through the transferrin, it is going into the bones, liver, spleen, everywhere in the circulation. It is going to travel with the help of the transferrin in the circulation. But ferroportin should not be produced more, because iron, if it is enter more iron, it can cause the toxicity. So ferroportin will be inhibited by hepcidin, where it is hepcidin is coming from the help of the liver. So liver will send the signal to ferroportin to close the gate if already the iron, the normal iron is already sent. So this is like an inhibition. Next, moving on to the endocrine system, we have the types of the definitions. Autocrine means the same cell it is going to send the signal. For example, same cell it is going to send the signal. And paracrine, nearby cell. Okay, very beside cell. Okay, like that. It will send the signal very nearby only. Next, endocrine, via circulation, it will send the signals. Endocrine mediation will be by the mostly in the negative feedback only. For example, hypothalamus will send the pituitary to the produce the hormone. Pituitary will produce the hormone by the systems, and once they produce, they will send the signal to the pituitary, please stop, we already produced, and it will also send the signal to the hypothalamus, please stop, it's already normal. So this is what the negative feedback. You are pulling back from the function. What are the hormones that is what are the precursors that is produced by the hypothalamus? TRH, CRH means thyroid releasing hormone, and also corticotropic releasing hormone, gonadotropic releasing hormone, and the growth hormone releasing hormone. When it is comes to the pituitary, thyroid stimulating hormone, and this is the adrenocortical hormone, and next follicle stimulating hormone, and luteinizing hormone, growth hormone, and antidiuretic hormone, and also the oxytocin. And ADH and oxytocin is also produced by the anterior, but they stay in the posterior. Okay, remember that nothing is produced by the posterior, they only stay in the posterior, but it is produced by the anterior only. Next, by the systems, T3, T4, cortisol, prolactin, testosterone, estrogen, progesterone, those are all are produced by the systems. Next, so here you can see, this is the pituitary gland, where the anterior pituitary and posterior pituitary, and the posterior pituitary ADH, oxytocin, but the acting only, the function only coming from here, but the most of them are produced by the here only. Okay, that is the first thing that you have to remember. Next, growth hormone is going to work by the JAK-STAT pathway. So hypothalamus will send the signal to the somatotropes in the pituitary, and it will produce the growth hormone, and this growth hormone going to play the role in the liver, and liver produce the insulin like growth factor. So which is the active product of the growth hormone. So how the growth hormone will increase? Whenever you are fasting, whenever you are doing the exercise or starvation, adolescence age, the growth hormone will be very high. In the adolescence for the growth spurt, and in the starvation fasting to compensate the glucagon, because it is also considered as a counter regulatory hormone, and also helpful for the protein synthesis, lipolysis, epiphyseal growth of the bones, and chondrocyte proliferation of the bones. All this will be the main functions of the growth hormone. Next, coming to the prolactin. Prolactin is produced as same as again the hypothalamus lactotropes prolactin. But prolactin is inhibited by the thyroid hormones and also the dopamine. It will always send the signal to not produce by the dopamine. And next, TRH will increase the prolactin. See the difference here. T3, T4 will decrease, but from the hypothalamus, TRH will increase the prolactin. Next, gonadotropin releasing hormone will be inhibited, right? Gonadal hormones will be inhibited if there is an excess of the prolactin. That's why the patients will be having the amenorrhea symptoms. Next, coming to the thyroid, which is a very important. Thyroid, we all know that hypothalamus TRH, TSH, T3, T4. But how the T3, T4 is synthesized? We all know that the thyroid is produced from the thyroid gland, but let's see how it is going to. So first we are going to get the iodine from our food. Okay. Once it is reached the circulation, along with the sodium, symporter, it will enter the cell of the thyroid. This is the follicular cell, this is the colloid region. Okay, this is the circulation. Once this iodine will entering the cell of the follicle cell of the thyroid, it will enter into the colloid, because the most of the product formation will be take place in the colloid only. Once it is enter the colloid, it is going to converted as an iodide. Okay, these iodide is going to form the thyroid globulin and the iodine will form together and form the monoiodothyronine and diiodothyronine. And once they are formed, they are going to form the T3 and T4. Right? Monoiodine means T1, diiodine means T2. If they both combine, T3 is formed, T2 is formed, then T3 is formed. So like that, the precursors will be formed here. Once they enter, they are going to convert it back and send back to the circulation. So first step will be iodide trapping from the food and then oxidation of the iodide. Here you can see the conversion and next organification here and next coupling the thyroid globulin and also here the coupling, then storage and transport to the circulation. These are the important steps of the thyroid. Next, Ull-Chekhov phenomena. What is Ull-Chekhov phenomena? Whenever you take the more and more iodide, it will stop the organification. Once if it is stopped the organification, the patient will be having the hypothyroidism. No symptoms, but hypothyroidism will be seen. Jade-based phenomena. You again taking the excessive amount of the iodine, but it will cause the disease. Okay, hyperthyroidism will be seen in this patient. Next, simply the thyroid hormone will be increasing the basal metabolic rate. Like T3 is a very rapid action, short acting, short half-life. T4 is slow, long acting and long half-life. And also these hormones will be acting on the beta receptors, ionotropy and proteolysis, lipolysis, myelination, skeletal growth, mental health. Everything will be depending on this basal metabolic rate of the thyroid hormones. Next, coming to the adrenal gland, we all know that adrenal gland has three important. One is the zona glomerulosa, zona fasciculata, and zona reticularis. Inside is the medulla. What are the hormones by the glomerulosa? Mineralocorticoids such as aldosterone. Fasciculata, glucocorticoids, cortisol, corticosterone, cortisone. Reticularis, androgens, dihydroaldosterone. Medulla is going to produce the epinephrine, norepinephrine. Okay, this image is also asked in the examination. How can you remember? GF, outer to inner GFR, glomerulosa fasciculata reticularis. Let's see the action of the aldosterone. It is going to act on the epithelial sodium channels. It will increase the sodium, decrease the potassium. On the compensation, it will increase the BP. Cortisol main action will be counter-regulatory hormone, proteolysis, lipolysis, anti-inflammatory, increase the glomerular filtration rate, increase the calcium, increase the gastric acid. So this all counter will cause the side effects in the body whenever you take the excess of the iatrogenic glucosteroids. Sex steroids will be helpful for the pubic axillary hair sexual libido. Next, medulla is produced by the norepinephrine, epinephrine. It will increase the sympathetic activity, increase the alpha and the beta receptors activity. Right? We also have the small hormone, parathyroid hormone. If this is an, let's say this is the thyroid gland. In the back side of the thyroid gland, there are the four small lobes. These four small lobes will produce the parathyroid hormone. Parathyroid hormone is made by the amino acids, 84 amino acids, and from the chief cells of the parathyroid gland. Next, whenever there is a decreased calcium, immediately parathyroid hormone will be activated. Once it is activated, it is going to act on the three important structures. One is the bones, kidneys, and the intestine. How? So whenever it act on the bones, it will block the osteoclast and more bone resorption will be seen. If the bone is resorbed, calcium will be increased, right? Because the triggering factor is decreased calcium. And in the kidney, it will block the excretion, sorry, it will increase the excretion of the phosphate. So it's like a opposite action. If the calcium is high, phosphorate should be low. Okay, so if you send the more phosphorus outside, more calcium will be retained in the body. So in the kidney, it will send the phosphate outside. On the intestine, it will increase the vitamin D secretion and also increase the calcium absorption. So further, it will increase the calcium levels in the body. Next, coming to the reproductive system, male reproductive system. So we all know that the gonadal cells in the birth will produce the after during the puberty whatever the testis having the spermatogonium. With the help of the mitosis, it is going to produce the primary spermatocytes. Okay, So these primary spermatocytes will be produce secondary spermatocytes with the help of the meiosis 1. Okay, this is the first meiosis, and the secondary spermatocytes will produce the another meiosis, and it will cause the spermatids. Okay, so 60 is to 4. If you have the 60 spermatocytes, it will produce the 4 spermatids. Next, until here, this is known as a spermatogenesis. Spermatogonium is converted as a secondary spermatocytes is known as a spermatogenesis. Once the spermatids is produced, it has to convert them as a spermatozoa. This phase is known as a spermiogenesis. And spermiation is nothing but the sperm is getting out. That is what spermiation. Sperm mature in the proximal epidermis. Sperm motility is increased in the distal epidermis, and spermiation is process done in the seminiferous tubules and release of the sperms. Half-life of the sperm is just 72 hours only. Next, hypothalamus is produce the gonadotropin releasing hormone. It will act on the anterior pituitary, produces the follicle stimulating and the luteinizing hormone. Follicle stimulating, remember that the word itself here, the FSH, so it will act on the Sertoli cells for the spermatogenesis. Next, LH, L for Leydig cells, it will produce the testosterone. And once they are reached, they are going to produce the inhibin will act on the anterior pituitary to stop the production. This question is also asked in the examination. These questions is also asked in the examination. Do not miss these questions because this already asked in the PYTs. Erection is due to parasympathetic activity, but ejaculation is due to sympathetic activity. Female reproductive system. Again, gonadal cells will produce the oogonium, and these oogonium produce the primary oocytes. This is happening in the birth only. During the birth only or in the intrauterine life only this is happening. They will be arrested. Primary oocyte will be arrested. At what phase? At the prophase 1 diplotin stage, the primary oocyte is going to arrested. Okay. During the puberty, these primary oocyte will going to convert and it is going to enter into the secondary oocyte, and again the secondary oocyte is going to arrest at the metaphase 2. But when this arrest will be released, the first arrest, the diplotin stage will be released before the ovulation, and second metaphase arrest will be released before the fertilization. And ovum half-life is just 24 hours only. Next, pulsatilely the gonadotropin releasing hormone at the puberty it will release, and the FSH will act on the granulosa cells, LH will act on the theca cells, and theca cells will produce the whatever the important like cholesterol, androstenedione, and granulosa will produce the estrogens. Okay, these are the important types of the estrogen production in the body, and all the other important points will be discussing over the female reproductive system in the OB-GYN. And stay tuned guys, soon we are going to release the triple R book, and these triple R book will be helpful for the revision, and along with that there will be also continuously there will be rapid revision programs in the May month. Okay, so until then, stay tuned and don't forget to read and revise regularly. And those who are new to this channel, please do subscribe and share with your friends. Until then, happy preparation. Thank you, everyone.